So we've moved out of reproductive cancers and we're moving on into colorectal cancer. Statistically speaking, according to the NIH, in 2021 there were 149,500 new cases of colorectal cancer in the U.S., and it has now moved into the third most common cancer spot and is the second leading cause of cancer death. Most of the clients are over the age of 50 years old. However, those numbers are lowering, so we're looking at younger and younger incidences of colorectal cancer. It can metastasize, and the most common sites would be the regional lymph nodes and then the liver. Unfortunately, only 39% are diagnosed in early stage, but with early diagnosis and treatment, the 5-year survival rate is 90%. What is colorectal cancer? It's a cancer of the rectum or of the colon, which is that large intestine. All right, so risk factors. I'm going to say this hopefully every time, if I can remember to do it, that risk factors are vital. They help us to know who to help and how significant their risk is, especially when we consider multiple contributing factors, and especially if they're ones that we can't change. So in this instance, modifiable risk factors include diet, and when we look at diet, we're talking about low fiber, high fat, high processed meats, and diets that are low in fruits and vegetables. Other lifestyle considerations, having a sedentary lifestyle or a lack of physical activity, smoking or alcohol use, and overweight and obesity are considered high risk factors for colorectal cancer. When we look at non-modifiable, we already alluded to age when we looked at our statistical PowerPoint. This is greater than age 50 is a higher risk factor for colorectal cancer. However, that number is going lower now. We're seeing it in younger and younger incidences in our Western society. Ethnicity, African Americans are at the highest risk for colorectal cancer. Having a personal history of polyps, so if you've had a colonoscopy or if you've had a history of polyps, that puts you at a higher risk. Inflammatory bowel disease, Crohn's disease, or ulcerative colitis put you at a higher risk for colorectal cancer. Having a family history, meaning a first or second degree relative, and then genetic syndromes. And before we go further into the diagnosis PowerPoints, I want to distinguish between these and the diagnostic tumor markers that we use. These genetic syndromes are DNA mutations that can be measured when we take labs and when we look at genetic anomalies. When we talk about manifestations or symptoms, it's important to know that actually colon cancer can be a very slow growing cancer in most cases. So some patients are asymptomatic until the cancer is more advanced. Symptoms can depend sometimes on where they occur in the colon, so where that cancer is located. But overall, when we're talking about earlier symptoms, we're looking at blood in our stool. So hematochezia, the red in our stool, or melena, the black tarry stools. If the cancer is in the rectum or that sigmoid colon, you're going to see more of that red. If it's further back in the colon, closer to the small intestine, you're more likely to see that melena or black tarry stool. And anemia along with that, right? We're losing blood, so eventually our body's not going to be able to come up and make up for that blood loss. You might see changes in stool or in bowel habits. That's an earlier symptom. And then cramps and gas and bloating. When we're talking about later symptoms, more advanced stage disease, we're talking about potentially palpable masses that can be palpated through the abdominal wall. Weight loss and fatigue. We emphasize this over and over again that cancer is highly metabolic. With the GI cancers, the colorectal cancers also, there's always that possibility that you are interfering with the patient's ability to eat, that the cancer is causing them to have nausea, vomiting, feelings of fullness. Again, we talked about that abdominal fullness, rectal pain. So any of these sensations can interfere with the patient's ability to eat and can contribute to that weight loss. So when we talk about lab work, we're going to look at a CBC. I mean, we always look at CBCs. They're very important labs to have. But in this specific case, we're looking at the red blood cells and the hemoglobin. And the reason for that is because of that potential of an early symptom of GI bleed, which could contribute to anemia. So that's why we're looking at the CBC. It's one of those correlative labs. We might be looking at fecal occult blood samples. Again, many people who are not willing to do colonoscopies, they may buy into doing a fecal occult blood, which is just that at least two stool samples over 3 days, and positive blood in the stool. Now the CEA, this is one of those, not the genetic markers that we're looking at, right? We know that, as we discussed in that previous lab, those genetic markers like Lynch syndrome and BRCA, those are genetic mutations. The CEA is actually an antigen, and it's the body's response to the presence of cancer. So we know that when the body fights back, that immune system creates those antigens, and that's what we're talking about here with the CEA. What we look at with the CEA is we can use it early on to get a baseline. So if we believe that the patient has colorectal cancer, we're going to be looking for the CEA, because even though it is associated with other cancers, it's very frequently associated with colorectal cancer. And then we monitor it later on as a good way to see whether or not the patient is responding to therapy, and we may monitor it post-therapy to monitor for recurrence, so when those levels start to elevate again. As far as imaging goes, we're going to be looking at imaging of the abdomen. So we can use x-rays, we can use ultrasounds, we can use CTs and MRIs, and obviously they give us increasingly distinct images. As far as procedures go, we might do a sigmoidoscopy, although this has really kind of fallen out of favor. It's not used quite as much because really the gold standard for any colorectal cancer or colorectal screening would be the colonoscopy, because that allows us to go from the anus all the way through to the opening of the small intestine. In a sigmoidoscopy, we're simply going up through the anus into the rectum and looking at that descending sigmoid portion of the colon. Now again, let's dig into that CEA a little bit. CEA stands for a carcinoembryonic antigen. Again, antigen being the body's response to a foreign invader, in this case colorectal cancer. It's a specific protein. This level increases with certain types of cancer. So we'll also see it with bladder, breast, lung, ovarian, thyroid, but most commonly we're going to see it with colon cancer. And as I said, we're going to look for it before treatment as a baseline, during treatment to assess response to therapy, and after treatment to monitor for recurrence. So we talked about colonoscopy and sigmoidoscopy, and I put these images in here so you can kind of see the areas to which these are able to actually assess. And so a sigmoidoscopy actually can detect about 50 to 65% of colorectal cancers. You look at the colonoscopy here, though, it goes all the way up over and actually down into the opening of that small intestines. So it's actually more effective at assessing everywhere that we might expect to find that colorectal cancer. Again, 50 to 60%, that's a lot of cancer to miss. 40% is a lot of cancer to miss. Endoscopy is just entering the scope per orum or rectum. That's what endo means. Anoscopy means scope. We talked about that sigmoidoscopy, that shorter scope for the anus, rectum, and descending colon. We talked about the colonoscopy for the entire colon. And then there's something called an esophagogastroduodenoscopy, or EGD. And this is when we go in through the mouth and we can look at the esophagus, the stomach, and into that very first part of the small intestine. Ultimately, we want our patients to be getting some kind of regular testing. So whether that's yearly fecal occult blood, because if there's the presence of blood, we're going to be having them get further study, right? If they're going to end up needing that colonoscopy. And it's not as accurate as getting the colonoscopy itself, but it's a good start for patients who are not willing to have a colonoscopy without cause. But the colonoscopy is what we consider the gold standard. It's the best and most accurate way to assess for colorectal cancer, and ultimately some biopsy can be performed during that. So if there's small polyps, they can be removed. We can do cauterization, and we'll talk about some of those later, but colonoscopy is our gold standard. I put this slide in here because, again, it just kind of shows you those stages of colon cancer. And we talked about stages before, but this is a great image, right? We look at that stage 0 where the cancer is in situ, stage 2, and then, of course, moving up here to stage 3 where it's starting to breach through the intestinal lining. And you can see some in the lymph nodes here, and then stage 4 where it actually breaches through the intestinal lining, perhaps affecting other organs and in the lymph nodes. Let's move on into prevention and management, and we'll start with prevention. We'll start with primary prevention. So when we look at primary prevention, we're kind of looking back at our risk factors again, right? Right back up there to our risk factors, looking at those things that we can control that influence and increase our risk for colorectal cancer. So some of the things that we can do preventatively are diets rich in calcium. Calcium binds to free fatty acids and bile salts in the lower GI tract and helps move them out of the body. We're going to focus on that low fat, high fiber, and complex carb diet. Exercise and activity to work against that risk factor of a sedentary lifestyle. Obviously, if someone is smoking or alcohol abuse or use, high use, we're going to talk to them about smoking cessation and alcohol moderation. And of course, obesity, we're going to talk about weight loss and maintaining a ideal weight. We're also going to talk about, for those who are at high risk, they have that family history, we're going to talk about genetic testing. When we talk about prevention, we're also talking about secondary prevention, which is where our screenings fall under. When we talk about average risk, we go back and we look at our risk factors, and people who don't have those risk factors are average risk people. And so when we're talking about average risk screening, we're talking about colonoscopies that begin at the age of 45 years old. It's going to be earlier for our higher risk patients, 40 years old, or depending on the level and the number of risk factors, multiple risk factors. That's going to be a conversation to have with their primary care providers or their GI doctors. Fecal occult blood can be done annually, should be done annually at the very least. Again, if we cannot get patients to come in for colonoscopies, if they're just not compliant with that, we should be looking at the stool for the presence of blood as one of those earlier signs. Cologuard. So this is one that you haven't really heard about before, but this is actual stool DNA. This can be done every 3 years. And the great thing about this is we're looking at actual colorectal cancer DNA. We talked about sigmoidoscopy or colonoscopy. Those can be done every 10 years if they remain normal, every 5 years if they're a higher risk patient, or less if they're abnormal. And then something called a CT colonography, which is not invasive, but again, more expensive, not ideal. Colonoscopy is still our standard. I wanted to make a distinction here for you as well with these fecal testing. When we look at the guaiac, it is pronounced guaiac, that's our fecal occult blood. So it's just looking for blood in the stool, just as simple as that. And we said 2 positive stools within 3 days. The Cologuard, this looks for cancerous, precancerous, and blood in the stool. So it's a little bit more complete. This can be done every 3 years. And then genetic testing with the family history, we talked about that a little bit with that Lynch syndrome and BRCA. When we're talking about tertiary prevention, we're talking about treatment. What is the treatment for colon cancer? Well, it's pretty much the same as what we've been talking about in our cancer overview and with our breast, ovarian, and prostate cancers. Most likely, it's going to start with surgery. It includes pharmacological treatment, so that can be chemotherapy or targeted therapy or immunotherapy, and radiation. And we'll just kind of shape that out a little bit here in the next slides. I put this together because I thought it was interesting for you. What order of treatment are we going to promote for colon cancer? And really, it's going to kind of be stage dependent. So you can see surgery is usually our first step in the process, just like it was with breast cancer, and then our pharmacology, and then our radiation. In this early stage with the 0 to 1, sometimes it is enough just to do the surgery. Depending on the margins, we've talked about margins before, so they remove the primary tumor and they take a reasonable amount of tissue surrounding that tumor and check for cancer in that tissue. And sometimes that's actually enough. Patients would not need to proceed to pharmacology or radiation. So, but that's in those early stages, 0 to 1. In stages 2 to 3, they're going to proceed through that same surgery, pharmacology, radiation, but sometimes they may have neoadjuvant, what we call neoadjuvant therapy, and that's therapy that happens before surgery. So we may do it to shrink that tumor and give us a better ability to resect the tumor from the colon. And then stage 4, again, surgery, pharmacology, radiation. Sometimes we have that neoadjuvant therapy before surgery to help shrink the tumor. Let's talk about our surgeries. What kind of surgeries are we talking about when we talk about colorectal cancer? Well, we may be talking about local excisions, and we talked about this a little bit when we talked about the colonoscopy. We can put that scope in. We can cut off or cauterize off polyps. We can actually remove small tumors. So that's called local excision. And then we can do fulguration. And this is when we take that same endoscope, but we have an electrocautery tool, and that helps us to destroy malignant tissue. That can decrease the size of the tumor. It requires several treatments, and it's used for patients who are poor surgical risk. So as far as the anesthesia that we need and the length of surgery and their ability to recover from surgery, some patients may not be a good surgical candidate, and so this is an option that we have that we can attack that cancer without a full surgical procedure. But the standard of surgery is this colon resection or colectomy, and this is where we remove a portion of the colon. And you can see here they have it divided up into parts. This is a highly vascular, highly lymph concentrated area. So they may take that section of the colon out and then anastomose it with the remaining sections, joining them together. And then they're going to do regional lymph nodes. So the lymph nodes that are associated, those sentinel lymph nodes as you come off of the organ itself, they're going to check those for cancer. And this, as we said, may be curative. We may be able to remove that section of the colon, and that may be it for the patient because of the cancer being in situ or non-invasive to the wall of the colon. For patients, when we talk about that colectomy, we may be taking part or all of the colon even. This colostomy is what we do to promote that temporary healing. So if we do take portions of the colon out, you can see that we make that ostomy in the outer part of the wall. And I know you learned about this in your 150s with your GI studies, but we're bringing it forward here into a new diagnosis and a new disease. So this ostomy is normally the most common one, is this sigmoid. You can see over here a sigmoid colostomy in that sigmoid portion of the colon. But we can also have them up in the transverse colon. We can have them over here in the ascending. So they can be all different places. But this is a way to promote temporary healing. So we're diverting stool from going through that anastomosed area where we rejoined those sections of the colon after we took a section out, and we allow that surgical incision to heal cleanly. So when we talk about pre-op, post-op concerns, pre-op, almost like like we prepare for a colonoscopy, there's going to be clear liquid for several days before surgery. So patients are going to complete that bowel prep. We're going to get that all cleaned out, and then give them prophylactic antibiotics, because this is not a clean surgery. Obviously, this is one of the dirtier parts of the body. As far as post-op concerns, our responsibilities are to assess that stoma. If you recall, when we were looking at the stomas, we're looking for that necrosis or that frank bleeding, right? It's normal to have a little bit of bleeding with a stoma when we provide care because it's highly vascular, but we don't want any of that frank bleeding. Because this is a GI surgery, we're going to be watching that intake and output. So we're going to be watching urine and fecal output. And of course, this challenges you to think back to your renal studies where we know that urine output should be greater than 30 mLs an hour. Patients may have nasogastric suctioning for decompression, just allowing that bowel to heal and regain function. And we're going to be monitoring for that return of bowel sounds and then stool and urine output. So good bowel assessment is important at this stage. And then of course the patient may start with TPM, but will progress that diet slowly. So they're going to work through liquid diet to puree diet and so on, and they will be advanced as tolerated. As far as education that we provide the patients, again, revisiting your 150s, we're going to provide ostomy assessment and care. We're going to teach them about care of their incision, limitations to surgery, no heavy lifting, and of course, they're going to be reinforced. That's their surgical care team who's going to be making those decisions, but we're going to reinforce that education with them. It says here to resume normal activity in 1 to 2 weeks after laparoscopic or 4 to 6 weeks after an open procedure. We're going to probably advise them to pay close attention to how they're feeling and to take things slowly and give themselves some good healing time. One of the really important parts of post abdominal surgery care is post-operative pain control. We are going to monitor for adequate pain relief. So we're doing regular assessment for our patients. We shouldn't be waiting for them to come to us. We're going to check in with them to make sure that their pain is controlled in that they can do the things that they need to do, eating, sleeping, and getting up and moving. We're going to monitor for which of our analgesics are most effective. We're going to make sure that they have that analgesia before activity. So if they're going to be working with physical therapy, we want to make sure that they have pain control before they do that in order to get the most out of the activity. We're going to be assessing the incisions for inflammation, swelling, and infection, like we do with any incision. We're going to assess the abdomen for distension that might indicate some type of leaking. And we're going to monitor for bowel sounds so that we don't have an ileus, meaning that either post-surgically because of the medications and handling of the intestines, the bowel actually stops its peristaltic movement. That's called an ileus. And so we're going to be monitoring the patients for signs that that might be happening. And one of the ways that we do that is with the return of the bowel sounds. And then we have to teach them, as we do with all abdominal incisions, to splint when they're coughing or deep breathing. Pharmacological therapy associated with colorectal cancer, chemo, again, with radiation before surgery to shrink the tumor. We might give it after surgery to prevent metastasis, or we might use it palliatively to shrink tumors and to relieve symptoms. You saw this a little bit with the breast cancer regimen when we talked about the HER2 negative cancer and the AC-T regimen. A lot of chemotherapy regimens are like that. They have acronyms. And in this case, it's no different for colorectal cancer. Two of the most common that you'll see are these FOLFOX and FOLFIRI. And these stand for the medications that are included in the therapy, just like they did with the breast cancer HER2 negative therapy. These cycles usually last about 4 to 6 months. This is not something that I'm going to be testing you on per se as to how a regimen goes, so I don't need you to memorize what days they get what. But I do want you to be aware for your own knowledge that cycles typically last about 4 to 6 months, and some can even go longer, depending on how the patient tolerates them. But these are some pretty heavy-duty chemotherapy drugs here. FOLFOX and FOLFIRI. So day one might look like this. They may get an infusion of 5-FU, they may get some oxaliplatin, and then they'll get something called leucovorin, which is actually going to help them to offset some of the side effects of the other chemo drugs. Day two, they're going to go home. Well, they're going to go home day one with a pump. It will start up on day two, and they will get a 24 to 36 hour infusion of 5-FU, and then the pump shuts off. They have home health care teams that come in and actually handle the pump removal for them. And then they are off in their cycle. So they have days 3 to 14 to rest and recover. And you remember, these drugs are going to affect our blood cell counts with that bone marrow suppression. So it's during this time that we're really monitoring those. We're waiting for what we call the nadir, which is that point at which the chemotherapy is most effective. And so we're going to see that in the bone marrow suppression. That's when our numbers are going to be lowest. And then, of course, they'll start to recover from that treatment. And then about the time that they're recovered, it's time to start another cycle. We talked about oxaliplatin or FOLFOX. Oxaliplatin is part of that. You can see I highlighted the ending here, that platin. That's because this belongs to a class of drugs called platinum drugs. Its method of action, it blocks duplication of DNA in the cycle. So this is like most chemotherapies that work to kill fast-growing cells. It's working within the cell cycle to disrupt that replication of the cancer cells. The common side effects with this one are neuropathy of the hands and feet, sensitivity to heat and cold. So we're advising patients at this point to wear gloves and keep gloves by their refrigerator and freezer when they're handling cold things. We encourage them to drink room temperature drinks because it can actually, it's what they call a feeling of ground glass. So when they go to swallow those cold liquids, it's very painful. It can be very painful. We have bone marrow suppression, which we talked about, that anemia, thrombocytopenia, and neutropenia, also a part of treatment with this medication. Fluorouracil or 5-FU. You're going to see this one again when we get to skin cancer because there is a topical form, but in this case it's an IV infusion. Its method of action is that, again, like all chemotherapy, it blocks the cell's ability to make DNA for replication. So it's interfering with some part of that cell cycle development. Side effects for this one can include GI side effects, nausea, vomiting, diarrhea, loss of appetite, and stomatitis. And of course, you've learned about stomatitis and how to treat that when we talked about the breast cancer. So here it is popping up again. So these are the things that we're really watching for these patients. We want to hit them right away so that it doesn't interfere with their treatment, right? Best treatment is to get all the medications that have been prescribed at the doses prescribed for the frequencies for the duration, and that's best prognosis for the patient. So it's up to us to be knowing that these are the things that we're watching for with fluorouracil, monitoring our patients, encouraging them to call us and work with us at the first sign of any hint that they're having a problem with their medication. And then of course you can see bone marrow suppression because it is chemotherapy. We might expect to see that happen. Bevacizumab, this is a little bit different here, and now we're moving on into those immunotherapies or targeted therapies. You can see that I highlighted the end here. This MAB means that it's a monoclonal antibody. So again, we're working with the immune system. This ZOO, if you look over here at this chart, this is just an FYI. Obviously, I'm not going to test you on this, but it's absolutely fascinating. But we're putting these medications into the body with genetic material. And so when we do that, you can see over here, MOMAB means that there's mouse antibodies, right? Chimeric is a mix. ZUMAB is humanized. MUMAB, human. So whenever you can see the blue usually is what tells you what they've attached it to. And then MAB means it's a monoclonal antibody. So just a little fascinating side bit of how immunotherapy and particularly monoclonal antibodies work. As far as what a monoclonal antibody does, in this case, this one is called a VEGF. And what that tells us is that it inhibits that angiogenesis. So when we talked about cancer treatment in a general way, we said that cancer cells have the ability to create vascular pathways for themselves. And so what this does is it inhibits that ability of the tumor to create blood pathways and therefore deprives the tumor of essential nutrients and inhibits its growth. So that's how bevacizumab works specifically. Some of the common symptoms that we might see, flu-like symptoms, those may happen the first couple times that you take the medication. With this one, we might see bleeding in the GI tract or the gums, and we might see neuropathy as well. If we're concerned about severe or emergent things that might interfere with treatment or that have serious consequences, we're talking about bone pain. It can cause dysphagia. As far as neurosymptoms, you might see headache, dizziness, confusion, and even seizures. So some very serious side effects that can be had with these monoclonal antibodies. But most people tolerate them pretty well. Another very popular one, you're going to see this in multiple cancers, is this nivolumab. And again, MAB, it's a monoclonal antibody. U means that it's human. This is what we call a checkpoint inhibitor. And what that means is that it blocks proteins that prevent the immune system from attacking the cancer cells. So obviously our immune system is going to be attacking those cancer cells. That's why we have that CEA, that cancer antigen that we're monitoring in this case. But what this does is the immune system is trying, but we said that cancer cells are very adept at preventing that body's natural response from interfering with their reproduction. In this case, this blocks those proteins that are produced by the cancer cell and allow the medication and allow the immune system to attack the cancer cells themselves. So it's really working alongside of our immune system. As far as common side effects, you're going to see fatigue, liver changes, potentially rash or blisters on the palms and soles of the feet. In this case, this one actually can affect your thyroid. So as part of their ongoing monitoring, those labs are ordered on a regular basis and they'll be monitored. It can cause muscle, bone, or joint pain. As far as GI symptoms, we might see loss of appetite, nausea, and abdominal pain. As far as severe and emergent, again, usually with the first treatment or so, this is when you're highest risk for this infusion reaction. And we know from our discussion on blood transfusion that when we see chills, itching, rash, hives, shortness of breath, we have concerns for an infusion reaction. This also has the potential to have nerve or muscle problems, and then it can cause severe skin reaction, so Stevens-Johnson syndrome. And that's a pretty traumatic experience for a patient. It's traumatic for a nurse to see those blisters all over the body. It's sudden and it's severe. And so those patients are usually treated with steroids to tamp down on that inflammation and reverse the syndrome. And then, of course, liver damage. So we're going to be monitoring liver function tests with this particular drug. We can have complications from our colon cancer. We're going to talk about bowel obstruction first as one of those complications. And this is just kind of a little diagram of how that pathophysiology of bowel obstruction occurs. So we may have an obstruction of some sort. Again, if you have a tumor in your colon, then you can understand why it might cause problems for stool to move freely through the colon. We may have fluid and gas buildup. The patient may then start vomiting. They may have increased secretions and bowel distension. And then, of course, that fluid shifts into the abdominal cavity. And once that fluid's in the abdominal cavity, it's putting pressure again on that colon and the intestines, and it's creating more obstruction. So that's kind of the basic pathophysiology, a simple pathophysiology of bowel obstruction. When we talk about classifications of bowel obstructions, one way that we classify it is by where it's located. So we may have small bowel obstructions. Most bowel obstructions, approximately 80%, happen in your small intestine. Okay, so we're listening to those more upper epigastric region for those lack of bowel sounds. A large bowel obstruction is generally occurring somewhere in that colon and the rectum, obviously. We can also make classifications based on sometimes what's causing that. So maybe it's mechanical. So we may have pressure from a tumor, adhesions from surgery. So we've done a bowel resection and now we have adhesions in the intestines, and it's interfering with normal peristalsis and stool movement. Non-mechanical, we have that paralytic ileus. Again, we're recovering from surgery, and because the intestine was handled during surgery, because there's opioids involved, that slowed or stalled peristalsis, that can create what we call a paralytic ileus, and so we have that potential for bowel to stall in the intestines and form an obstruction. We can classify them as partial or complete. So in a partial obstruction, gas or liquid stool can pass through the point that is narrowed in the intestines because of the obstruction. So there is some stuff coming out, but it's not normal. It's either gas or liquid stool. Once it becomes complete, nothing's passing. And of course, that's when we start to see that back up into the stomach, and that's where patients can have that emesis that smells like stool. As far as diagnostic studies, looking for that bowel obstruction, we might do an abdominal x-ray. That's going to show us where there's free air and where there's bowel distension. So that image that I showed you up on the previous slide, where you can see the stool collected and impacted in the intestines. We might do a CT, and that can show us the exact location of the obstruction if we suspect one, but we're not able to really locate it. Electrolytes, we might see low sodium and potassium. Again, we're interfering metabolically, so this is an instance where we might have metabolic issues. CMP, so we can look at all of those electrolytes with our CMP. We might also see an increased BUN, and that might be due to dehydration. So if you remember back when we talked about that, about the pathophysiology of that bowel obstruction in that previous slide, we talked about that fluid collection in the abdominal cavity, and that's that third spacing. That's fluid that should be moving normally through the body and in the blood and out the urinary tract, that has now moved into spaces in the body where it's not supposed to be. And so we may see this elevated BUN as a result of dehydration, and that may be one of the things that we consider when we're thinking corroboratively about whether or not there is a bowel obstruction happening. As far as manifestations that you might see with a bowel obstruction, obviously you may have that abdominal distension. Stool is collecting in the intestines, and if we have that third spacing of fluid, obviously we're going to have fluid in that abdominal cavity. And you can see from this picture here that it can be pretty extensive. Patient being unable to pass stool or gas, that's going to be a good indication that there is an obstruction. We might hear high-pitched bowel sounds above the obstruction. So when you're doing your 4-quadrant bowel assessment, you're going to be listening for those high-pitched bowel sounds prior to where the obstruction will occur because of the pressure that's mounting there. You might hear hypoactive or absent bowel sounds below the obstruction. And that makes sense. If the obstruction is keeping anything from coming through, you're not going to hear the intestines passing, performing that peristaltic movement after the obstruction location. And then, of course, that emesis with fecal odor, we already talked about that. So what are you going to do? What is your responsibility? You're going to be auscultating. Bowel sounds, as we just discussed in that previous slide, are very important to you to know what's going on. Okay, if you hear those high-pitched sounds, that's a good indication that you have an obstruction. If you hear an absence of bowel sounds, that's a good indication that you are post-obstruction. You're going to be measuring that abdominal girth, looking for signs that there's that third spacing of fluid or distension associated with stool collection in the intestines. You're going to monitor those lab results for electrolyte imbalance, and you're going to assess for abdominal pain, because depending on the level of obstruction that's occurred and how much stool is collected in the intestines, there is always that risk for perforation and peritonitis, both of which would cause pain in the abdomen. How do we treat or manage a bowel obstruction? So NG tube placement is our go-to in this instance when we're talking about treatment of bowel obstruction. The purpose of the NG tube is to relieve the stomach of its contents and to allow the bowel rest. So we're going to insert that NG tube, and you've done that. You've tested off on that skill in your 150s. You remember that we're going to insert the NG tube. We're going to verify correct placement and patency. So we're going to have a chest x-ray that shows us that that NG tube is in the right place. As far as suction, we're going to put it on low intermittent suction. We don't want to take out too much too fast, but we do rely on that to remove the stomach contents and to allow the bowel to rest. What we're doing is we're assessing Coca. We're going to note the color amount and consistency of the drainage that's coming out into the suction canister. And of course, we have to check that nasal area for skin breakdown. That can happen pretty quickly, so we want to make sure that we're keeping that NG tube in the right place, and that we're looking, especially in a patient who is compromised now as far as what they can take in, their skin becomes a risk factor, and so we're watching for skin breakdown in that nasal area. And then they're going to remain MPO, so they're not taking anything in by mouth. That would kind of defeat the purpose of the NG tube. And we're doing good oral hygiene on these patients. We're watching for fluid balance, so they are going to get IV fluids, and of course we're going to monitor intake and output. We could have some issues with GU output, so we're going to be monitoring that as well. And then we're going to be watching for that fever or hypotension, anything that would indicate that there's a fluid imbalance or potential peritonitis, as we discussed before, or perforation. Depending on how long the patient has the NG tube in, TPN might be a option for these patients. It's also known as intravenous or IV nutrition feeding, and it's a method of getting nutrition into the body through the veins. Again, the goal is to correct or to prevent malnutrition. It's a complex solution, so we have amino acids, carbohydrates, electrolytes, vitamins, and fats. It is individually made, so it's tailored to each individual patient. One of the concerns with TPN is that it does have a high dextrose content, so we're going to be watching blood sugars with these patients. If we have to stop it for any reason, we have to be careful that they don't have any rebound blood sugar issues, so we're going to be watching for that as well. This is only administered through a central line and always via an infusion pump. And it's indicated when the client can't meet their nutritional needs through oral feeding. That large bag, you'll see them on the floor. Hopefully your instructors will be able to point some out to you, but they're administered over 24 hours. Usually the lipids run in over a shorter time, usually about 6 to 12 hours. But that TPN bag, it runs for 24 hours. If it's not done after 24 hours, it's taken down. It requires specific tubing, so you can see here in this image that I've included, this is what we call a micron filter. It's a 1.2 micron filter, which is what we use for our TPN, and that's used to keep anything too large out of the blood vessels. So some concerns, some of the things that you're going to be watching for. Infection, always. We're using a central line site, and this is nutrition, so we do have concern for infection. Again, highlighted in red, bag and tubing changes every 24 hours. We talked about that rebound, that hyperglycemia, because of that high glucose content. So we're going to be monitoring the blood sugars, and we're going to be prepared to taper the patient if they have to stop that TPN for any reason. We're going to have to perhaps supplement with some dextrose should there be a problem. Another concern with these patients is fluid overload. That's a lot of fluid to be putting in a very short time. And so, and because of the electrolytes in it, it's actually considered a hypertonic solution. So this may cause fluid to shift into vascular spaces. So we're going to be watching for signs of fluid overload, which of course is our pulmonary symptoms, that crackles, difficulty breathing, shortness of breath. So we talked about some of those concerns in the previous slide: infection, blood sugars, and electrolyte and fluid balance. So what are some of the priorities that you are responsible for related to this TPN and trying to prevent some of those potential complications? You're going to be checking the provider's daily order. Again, I told you these are individualized formulations, and so you want to make sure that what is in the order is what is coming through on the patient's bag. You'll get an order set. So this is something that kind of goes along, it's programmed into the system, and these come along with this TPN infusion. So you're going to be doing daily weights. Again, when we talked about this in our renal studies, we know that the best way to look for fluid overload is to perform daily weights, and so that's why daily weights is a part of this. Daily labs. So again, specific formulations, concerns about electrolyte balances, blood sugar, things like that. Even white blood cells, which would indicate infection or peritonitis. Those are going to show up in our daily labs. We're going to monitor intake and output. We're putting a lot of fluid in. We want to make sure that it's coming out. And then those bedside glucose checks every 4 to 6 hours. Again, highly concerning for high blood sugar. The initial rate is usually 50 milliliters per hour with gradual increases to a maintenance rate. We're not going to change the rate to catch up because we're not going to pump that much sugar into the patient. All the tubing and solution is discarded every 24 hours. Again, this is nutritious, so we're not going to risk infectious and bacteria. We're going to get rid of all that tubing and solution every 24 hours. Whether or not that solution is completely in 24 hours, it is tossed. We said about monitoring for fluid overload. Again, that dyspnea, crackles, edema, those are the kinds of things that we're watching for. We're going to discontinue TPN by weaning it slowly and monitoring those changes in the blood glucose. Again, we don't want to have that rebound hypoglycemia. If we have concerns with blood sugar, we're going to infuse with 10% dextrose if we have to stop that TPN abruptly. And again, that's just to prevent concerns with the blood sugar. And we're not going to infuse any other solutions with our TPN.